Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
There's Kim.
I know
Do full screen.
this.
Yeah. That way you're looking at everything. There you go.
I know. But isn't this usually over there?
Yeah, but I must just be on your laptop.
There.
At least we got the fancy black memo.
We got the fancy black memo. Yeah. Sister's jacket. And it's IFM. And so you can hear forklifts in the background, maybe.
You sound great. It's nice and clear. The picture is nice and clear.
Oh, goody. Yay.
Hey.
Hi, I missed you.
I missed you. So much has happened. I have a graduate, actually. That's probably the biggest news.
You have a graduate. Who graduated from where?
Sophia graduated from high school.
Oh, Mom.
Yes. And
Oh,
super exciting. She's going to be following in the medical field, and she's headed over to the state of New York, right across the country. So there's that.
my gosh. So she got accepted where?
She got recruited, actually. So she'll be playing hockey. So she's going to Nazareth University in Rochester, New York to play hockey and to
Oh, but that's northern, that's upstate New York.
Yes. Yes.
No, upstate New York is nice.
Yes,
It is across the country.
it is.
You're going to have to, it'll be fine.
It will be fine. Yeah.
Congratulations.
Thank you. Yes, it's super
And-
exciting.
Is she's doing pre-med?
She's in between what field she wants to do. It started as pre-med. She's thinking about doing accelerated nursing program there, but we'll see how it is. Those first couple of years, you're just figuring it all out, and all those classes go together, and they're all so exciting.
Yeah.
So there's that.
When my daughter went to nursing school, I was talking to her about something and she said, Mom, you have to stop. I have to stop thinking like a doctor and start thinking like a nurse. And it's different. I didn't know how different it was, but
Right.
it's different. She'll figure it out. Oh, how exciting.
Super exciting. So we're just going through all the summer stuff, and summer is such a weird time for my practice. Just trying to figure out how to squeeze as much family time in as possible. Summer is different, like in the athletic world, because you're dealing with a lot of off seasons.
Yeah, yeah.
And
They
an athlete in an off season is you handle them so differently than an in-season athlete. Like the high pressure isn't there, but the attention to detail is there.
And the fixing the stuff that's broken is there.
So it's very similar to, and I was thinking about stuff about the podcast when we're talking with new clients versus existing patients and going through the history. I think it's so important to do a detailed intake at least once a year, especially with people that you don't see on a regular basis, because what they don't think is important is so important to us.
Yeah.
And
What do
it-
you mean you had the flu? What do you mean it was only,
Or talk to me more about these stressful events that you thought it was important enough to mention. Do you know what I mean? So if someone
Yeah.
had a lot of stressful events, it was obviously very important to them because they verbalized it. So
Yeah.
you can't just ignore that because it was something. If it was, it's not a big deal, they would have never mentioned it to you.
wow, there's no words. It's a genetic condition where there's a gene that makes a protein that allows your nerves to conduct impulses. And it's called SPG, spastic paralysis gene 7. And I have a patient that has SPG7, but she didn't have any symptoms till she was 40 something. So she comes in with foot drop and she looks on the bottom down like somebody with cerebral palsy, spastic diplegia, and foot drop. And you know that solfeggio frequency that I blow off a little bit. Yeah, whatever. The other word for it besides miracles is repaired DNA. And then I'm on text message with Ben Catholi while the patient is there and I'm working on her. And it's, Ben, what is this thing? It's an abnormal protein. I have a frequency for abnormal proteins. I could try that. He said, yeah, 120. So we tried 120. And when she came in last year, we worked on 81 and 10 to reduce the spasticity, and 81 and 396 to reduce the spasticity, and a little bit of 528. Nothing in the brain worked. And then she sent her unit in to be repaired. And when she got it back, I reprogrammed it with the same stuff. And she said, it doesn't work. Oh my God. So they flew from Texas and I treated her and it didn't work because the spinal cord was repaired. We had to work on the cerebellum, the sensory motor cortex. Basal ganglia wasn't a thing, but it was 528, repair the DNA, and 120. And this time, because it was all in the brain, I put the towel in her left ear and her left side in her left ear, and her left side all relaxed. And then I texted Ben Catholi, I thought the left side of the sensory cortex did the right side of the body. He said, yes. So he texted me back. It's 11 o'clock in Chicago, 10 o'clock. He texted me back and he said, yeah, but you're putting it in her ear, which is above where they cross.
Oh,
So it crosses down in the pyramids in the medulla. She didn't have a history of seizures. So I put a towel in each ear and ran 528 and 120. So abnormal proteins and repair DNA. And because she has one copy of the gene that works, we're trying to get that gene to turn back on. Her left side went completely smush. Her right side went 90% smush. And then she said, after we reprogrammed my CustomCare, it was about 6 weeks ago, I was able to, if I focus my attention, I can walk normally. Excuse me? Sensory motor, how, you're what? So she said, yeah. So we got rid of the spasticity. And I said, okay, I want you to focus. And sure enough, she walked without foot drop, without spasticity. And I said, do you understand that you are using a part of your brain that is not affected by that gene to change the function of the part of the brain that is affected by that gene? You understand that what you're doing right now is impossible? And just before I said that, she looked up at me. Her husband was out of the room and she said, it's getting worse, isn't it? I said, no, it's getting better. Then we talked about retraining her brain and that what she's doing is impossible. Then we had her walk down the hallway so we could get a video of it, of her walking without spasticity. Susan, the receptionist, was watching her and burst into tears. It was one of those moments that it's like choking me up already.
right.
It's like, this, it works. I can't, this wasn't placebo because she thought she was getting worse.
Right.
And her brain did something that's impossible. And she did it. I want a PhD in neuroscience. I want to download somebody's brain in a USB port in the back.
But even still, do you think that would help you though? I don't know those letters behind your name would give you any more clarity or any more insight into how.
I love being a clinical researcher, but don't you want to know? I want a squid axon. What we do with nerve pain is not possible.
Yeah.
What we do with the vagus nerve is not possible. And it's, oh yeah, it's just the vagus. Oh yeah, it's just Ehlers-Danlos. Oh yeah, it's just,
And when you hear yourself say those things,
I
And
check
the-
for whitening.
and then the patient looks at you like, did you just say that's easy to treat?
I went, usually there's never 100%, but yeah,
Right.
it's here. Let's measure it. As we measured everything
And you've seen her already. You saw her before, this person.
a year ago when it started, when what we had to treat was the spinal cord and the nerve.
And so let's talk about this for a second, because it crosses to one of the points that I wanted to make with my athletes. So the check-in, right? Whether it's after 6 months or a year. So we talk about programming custom cares, and yeah, you could program it to the year 2099, no problem. I don't like outdating my custom cares because I want that check-in, especially now with the software and the ability to give those patients updated programming. Because if we are right with our hypothesis and the treatment protocols, it should not work after a while. It won't be relevant because you've fixed the nerve pain, scar tissue, whatever else. Of course, there's some frequencies and some protocols that will always be there.
Neck pain, concussion and vagus.
You're
Yeah.
not touching those because they're perfect how they are. And if you ever need them, they're like the first aid kit that
You need them every day.
yes. But what I'm saying is, like, the one, like you said, you initially saw her and it was right to program 81 and 10 because the spasticity in the cord was indicated.
And when we use the frequencies for the brain, it didn't do anything.
Things change, right? And things evolve. And we talk about cellular turnover all the time. Like we don't have the same patterning, the same cells, the same situation in our bodies. It only makes sense that you're going to need to change things. But that was pretty drastic.
It was mind-boggling that, wait a minute, 81 and 10 doesn't work because it's not the spinal cord anymore. And we need to do 81 and 92 and 81 and 84. But we don't have, oh, and the pons. It isn't the cerebellum, it's the pons. So the pons mediates spasticity as well, based on one patient I had that had a pons stroke. She was spastic all over.
And what is pons? Do you know offhand? I don't.
Medulla has cranial nerves 10, 11, 12, and 9. And then the pons has 8 auditory, 7 facial, 5 trigeminal. I'm not sure what 6 is. And 8, 7, 6, 5, 4, and then 3, 2, and 1 are up in front someplace. So the pons is a section. I didn't know that it had anything to do with motor function,
Yeah.
but this girl had a pons stroke when she was 16. I saw her when she was 22, and she's completely rigid, spastic, and can't talk. Everything's spastic. And it's okay. So we treated 81 and the pons, and the spasticity in her upper body relaxed enough that the PT could mobilize her. And for some reason, you know how when we do 81 and 10, it softens up the front, then up the back. There's a pattern to it.
Yeah.
When we do the brain, at least when we do the pons, it's from the top down. When we do the sensory motor cortex in a stroke patient, the spasticity goes away from the top down. That's a good face because it doesn't make any sense to me either.
Okay.
But that's why I want a PhD in neuroscience. I want to know this stuff. I need to know more. There's holes where I want information.
But like I said, I think you would just find more holes because
I know.
this modality, that we have, doesn't play by any kind of rules that you can.
Well, we observe the rules by observing the effect.
Yes.
that's why in the core, the first practicum is observation.
Yeah.
And then the supine cervical practicum, we do 3 times because it teaches them observation with their fingers.
Yes.
Then it's observation with their brain. But it's clinical research. The first part of science is observation.
Yeah.
And so it makes it really fun.
I don't know what I enjoy more, is my reaction when a treatment starts working or their reaction when a treatment starts working, because, and maybe it's all of it. I don't know.
Mostly if the treatment starts working and it's really working, they're so stoned, they don't even, dude.
Right.
And so I think it's oh goody, there's a little happy dance going on inside, but inside we have to, at least outside, I act, oh, that's nice, it's working. We
Right.
don't want the patient to get too, that's pretty fun.
And again, no matter if you're treating like the athlete or patient, what you're describing, for both sides of the coin, it comes down to, and I'm using it almost every episode, is safety, right? It's the safety that they feel at disclosing their patient history form, being vulnerable to all the stuff that had happened to them, being vulnerable, safe to disclose the information, what they're feeling right now. When all those barricades come down, and then they feel, and then that safety to get the treatment and to accept the fact that the treatment is working. So there's all these little nuances.
And there's also safety. I love that you focus on that environment. It's a safety they feel when they've been injured by so many physicians before.
Right.
I had a patient recently, last week, I think. She had a benign tumor in the part of her ear where the bones are, middle ear. And the first surgeon in Southern California put a little slice in her eardrum, folded it back, took out the tumor, and you have to get every cell.
Right.
And it's benign. A year later, it grew back. And by then she was in Colorado, and a surgeon in Colorado decided that the best way to get access to this ear was to cut her ear away from her skull, fold it forward. Hang on, there's a forklift coming to pick up our boxes. Fold it forward and clean the tumor out that way. Tumor grew back. So somebody had to redo his surgery. So she comes in, she's got a vestibular injury that nobody warned her about, nobody diagnosed, doesn't know why she has disequilibrium, didn't even know it was called disequilibrium. In the process of doing this surgery, they damaged her trigeminal nerve. And so somebody thought it'd be a great idea, in order to stop the middle branch of the trigeminal nerve, they cut it with a gamma knife. And telling her what the symptoms were of a vestibular injury, getting her to take meclizine in the morning, especially when it's raining. She has spasticity in her masseter because of the damage to the facial nerve. And so I said, you take baclofen at night and you wake up with your jaw better in the morning. Try taking a baclofen in the morning. Ask your MD if that's okay. Okay. And the treatment to get rid of the scar tissue and the nerve hypersensitivity on the side of her head, the information about vestibular injuries, her BIVSS score is only 26, so she can still read but she can't go into stores. She can't go past trees. Now she knows why. I mean, it was 6 days that completely changed her life because of what we know.
And that's a really good point, right? And I think we do such a good job of patient education. It's not just putting a person in a room, hooking them up to the machine, pressing a button and leaving.
Yeah.
Where's the safety in that on any side? And you've been such an advocate for teaching this and keeping the professionalism, the standards of care so that it is safe. And so that comes through, I think, to the practitioners. I hope anyways, now that I'm also teaching and instructing, it has to feel safe for everybody. You have to feel safe as a clinician with what you're doing. And part of that is explaining. It's patient education.
Teach it, the more you learn it.
Absolutely. And so when people ask, oh my God, how could the core be 5 days? How could it take 5 days to learn how to use a little machine?
It should be 10.
But that's what they don't understand is it's not an ultrasound machine. It's not shockwave. It's not PEMF. It's not like that.
Have to think.
You have to think. Yeah. And I'm sure you get this too. Everybody contacts, oh, you should try this machine. Have you heard of this machine? And this one diagnoses you. And I said the other day, I'm like, what's the fun in that? I don't want to be replaced by AI or a robot or a algorithm.
I explain to people when they say this machine diagnoses X, and it's okay, can we look at that for a minute? What do you mean? Basically, any machine, the only thing that machine can do when you put your hand on it or they put little things on you is it reads a galvanic skin response. It reads the current and where it flows, how much of it is there. And then some person, based on his or her understanding or algorithm for how to interpret that current flow, that's his. And that machine is a galvanic skin response interpreter, period. The best and only diagnostic equipment that I trust is in between your ears, comes out of your blood or saliva and or urine. You have to get actual information. If you want a machine that does the diagnosis, is lazy an okay word to use?
Yeah. At the very bottom, it's just like uninvolved. Do you know what I mean? It's just, you're removed from it. When you're piecing the puzzle together, yes, it's absolutely brain numbing at times and frustrating, but it does force you. You say it allows you to. I've felt forced into situations where, you're calling. Thank goodness we have such a wonderful network where we can text practitioners and be like, this is outside of my wheelhouse. What could this mean? And then someone tells you, oh, okay, that would make sense. And you can connect your dots, right? So that's why it makes you a better clinician. If you're getting algorithms spit out at you, and that's why I never liked, excuse me to all my PT brothers and sisters out there, a lot of the PT modalities, because it was just heavily machine-based with no interaction.
It's a recipe. You do the same thing for everybody with shoulder pain, regardless of why or how they got shoulder pain. And
and as a patient who went through a windshield shoulder first, when I was in a room with the TENS machine and just say, when you don't feel it, turn it up. And somebody checked on me 20 minutes later. How you doing? Fine. Ice pack, just keep turning it up. That was my PT. And that's a good face. And
oh my gosh.
So yeah. And as a 20-year-old, I was like, all right. So that's why, and I'm not alone with this, where people are put into rooms with devices that there's no magic there for me.
Yeah.
I feel very grateful to have a device that I get to think and makes me a better person.
in your chat.
Look what Kevin just sent me. I don't know if you can read it. It says, it's not impossible. It's FSM.
And there's our new t-shirt.
That's Debbie. Thanks to you, Carol, I treated a horse with a cyst in his stifle. Can't harm, might work. 14 days treating, the cyst is gone. I had the horse re-x-rayed. The vet said, you sure that's the left stifle? I said, yep. He said, well, the x-ray shows it's not there. He said, that's impossible. And I said, it's not impossible, it's FSM.
Like I said, that's our new t-shirt for our new logo. Can you explain what a stifle is?
I think it's a horse's SI joint,
Okay.
but some of the horsey people out there are gonna have to tell me about that.
Okay.
And Catherine Adachi says, yes, 454 is the pons. And we have to learn more about, because if 120 actually works, because what Ben said was the mitochondria make proteins incorrectly, right? Gunky proteins. Does that make anybody else think about Alzheimer's?
Oh,
And I just talked to somebody at IFM whose company developed a test, and he described the tau proteins in dementia and Alzheimer's as they have a test for it that shows the misfolded proteins signal shows up in the blood 8 years before the patient develops symptoms.
wow.
Which leads you, the next question is, how do you stop the progress?
Yeah.
And the word he uses is hyperphosphorylation of proteins. Great. What makes proteins hyperphosphorylate? It's got to be inflammation.
Yeah.
And I don't know about you guys, but that's why I treat the vagus every night. And then you describe to this CEO that knows nothing about biology what the vagus does. It's motor, it's secretory, and it increases nitric oxide and blah, 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 blah. And his eyes glazed over and I said, I'll send you the webinar.
Yeah, because your Vegas webinar is fantastic.
I hope so. It seems to be pretty easy to understand and comprehensive at the same time.
I was just about to say a layperson can listen to it and not get totally nauseated or bored or fall asleep. And a clinician can listen to it and pull, oh yeah, this, and you can connect all your dots that way. It's good. I was just going to say something about what you were talking about.
Protein.
No, vagus nerve. Treating the vagus nerve. And you said something a few podcasts ago about when we're talking about, I think you're talking about like inflammation, when to use 40, when not. And you said, I just trust the vagus will control everything first, right? So making sure that your vagal tone is exactly where it's supposed to be, treating the vagus every night. Everyone bow down to the Lord Vagus because it dictates everything. So everything works better when your vagus nerve is doing its job.
And I can let the vagus decide how much inflammation I need.
That is how you worded it. Yes. That's on the t-shirt also. We have more Carolisms that we need to add to it, but that is absolutely true. And I think that's why ever since we've put the vagus in the rotation in the last few years, I think I'm getting exponentially better results, especially with the recovery modalities for my athletes, because it doesn't matter how hard you train, what you put in your stomach, what kind of supplements, vitamins, drugs you are taking. If you are not resting and if you are not recovering at night, it all goes out the window. And so getting good restorative sleep, I don't care if you're an Olympic athlete or a perimenopausal woman, things are going to be better if you are recovering at night, and treating the vagus nerve at night does that.
Yep.
Slam dunk. Like hard stop, like you need this at night. And I am out of custom cares right now because I am sending them home with people saying, I'm not treating you until your sleep gets better. So you're going to use this for a week and then see how you do.
Let's get your stress levels down and see where we're starting from. And when you can say to somebody, I had lunch with an IFM practitioner and the CEO today, and I said, POTS? He said, is there a vagal nerve stimulator? And I said, look, medical ones are implanted and they have a lot of side effects. Ours is external, and only my FSM practitioners know how to treat it until we develop a gadget that will treat it, but that's not my job. And what does that do? And it's patient comes in with POTS and 60 minutes later, they don't have it. Patient comes in with atrial fib and 20 minutes later, they don't have it until they have it again. Patient comes in with gastroparesis and 60 minutes later, they don't have it. And the MD that I was talking to, just her jaw dropped. It does that? Do you have a card? Believe it or not, I came to IFM. I have no business cards.
They can Google you. You're everywhere now.
It's
Yeah, no, for sure. Debbie just asked about sending a custom care home, like working out the charges. So I think it really depends on what the practitioner charges per treatment, what area of the country or world you live in, and where you are with your financial FSM investment. So I think it varies. So like when I teach sports course, when we do our little business practice management section, I don't put a set charge because I do think it really depends on my scale kind of slides. And I charged a little bit more for it when I was in Calgary because I was the only one doing it in Calgary. And I had just financially put a lot of money into all my FSM training, a precision care, a bunch of custom cares. So I wanted to make my investment back a little bit faster.
Sure.
So I think that just really depends on how many practitioners there are, what you charge per treatment. I charge a little bit more per treatment so that I can afford to give a custom care for a week and not charge for it. So because I'm almost selfish, because if that patient is treating themselves at night and I can get their sleep and restorative sleep better, they're coming to me in a better stable state so that when they're in the clinic with me, I can do more for them. So I think it really depends on all those factors. I don't know if you want to say much about
Enlightened self-interest. And the other thing we need is a copy, if you're willing to share it, of your rental agreement. I get requests for that every time I teach a core.
Yeah, I should just post it on my website because it's just very straightforward. How you take serial number CC blah, blah, blah in working order is how it's going to come back. And if it doesn't, a lot of times I will take a $2,000 credit card hold and then refund them.
Right.
That is the only way, because we have talked about horror stories of people, they just disappear. You can take their credit card, but what stops them from just canceling their card or saying that it was fraudulent? Or so if you're worried about the machine getting damaged, and you've always said it, if they can't afford to buy it, they can't afford to replace it. So the only way to do that is to put a hold, charge it, and then reverse it. You will eat credit card fees depending on who you use, but I think that's the only way. It's not a cheap machine.
And one of these days it will get cheaper, but right now it is what it is. I think that's a reasonable thing to do. I stopped sleeping when I got back from Taiwan because I had 5 different kinds of mold that I picked up, which turns off the vagus, which does a bunch of inflammation, which does blah, blah, blah. And dealt with that for 2 months before I had the testing. And then I still was not sleeping, even with drugs. And so I got my salivary adrenals. They were low in the morning and triple normal at night. I didn't wake up until 6 o'clock, and by 9 o'clock I was wide awake. So I tell my body to go to sleep at 9:30, and it's, dude, We got stuff to do. So my OBGYN put me on ashwagandha, 3 different forms of it. And like the sleep program wasn't enough. And when everything I knew how to do wasn't enough, that was the time to run another test, find out what was wrong, treat the mold, and find an herb that quiets the adrenals at night. And sleep is returning. So
everything works better if you can sleep.
yep.
So something I'm just going to add about the custom care rentals, if that's not in you as a practitioner's world where you can take a credit card hold and reverse it, or you don't want to rent it, just have them come in and run some programs in your clinic unattended. So that's the other thing, where they can come, maybe run it in the waiting room, or if you have an extra room, that way they're not leaving the premises with it, but you can run some things in the clinic. That's the other, it's not quite as nice as taking things home and running things in your sleep, but if you don't want to let it walk out the door, that's probably the next best option.
And in the core, the standard phrase is FSM patients take space, they don't take time. If you have a place to park them, then
That's one
that
way.
works.
Yeah. I just, like I said, for me, selfishly, once I made my investment back, and you do that quite quickly, I dare to say, then, like I said, selfishly, you want your clients and patients to come in as their most healthiest, best versions of themselves. So if they can come in rested versus sleep deprived, like, you're just going to do a better job that hour that they're in the room with you, and the results get better faster. And then they tell their friends, and then you're booked 6 months out. Like, it just really, the risk and the reward to me always just made sense to just take it for a few days.
Yeah.
And then they buy one anyways, because they never want to be without the athletes anyways, or even the weekend warriors. Who doesn't want to just recover from the stresses of being married, having a job, having kids, trying to go for a run on the weekends, all those things. It's just, like I said, now I've got a daughter going off to college, and she's not asking if she can bring a car with her. Can I bring a CustomCare with me? That is what we're worried about.
And that's the other thing that has happened with FSM, is that we have a whole generation of children that have been raised with this.
Yes.
And from the time I still remember Mike Andrews' 6-year-old son saying, when I asked him what his favorite programs were, so we were having this group dinner, and he came over, and he's got his little white shirt and his little blue vest and his little blue bow tie, clip-on bow tie. And he says, Dr. McMakin, I wanted to thank you for inventing FSM because of what it does for me and my family. And I swallowed hard. I know yes. And I said, so what are your favorite programs? And he actually had to think, and he said, the ones I use the most are when I come home from school and I've had a hard day. I have my mom run the concussion protocol on me. And if I have a test or something at school that day, on the way to school, we run Relax and Balance. Those are my 2 favorites. From a 6-year-old who's now in college.
Right.
Because that happened in 2002.
Wow.
Yeah.
That beats my kid's story when a mom came up to me and said, can I ask what you do for a living? And I was like, why? Your daughter seems to think that you could put children in a microwave when they get hurt. And I'm like, great. Now CPS is coming, not microcurrent. And here's my card.
And here's the website. I am a patient. I have a practitioner.
Yeah. I'm not microwaving anybody.
Hilarious.
No. So yeah. And again, going back to what we were talking about, the frequencies have changed, but they haven't, right? It's the way we're using them. I think about going back to basics and going back to the beginning and not overcomplicating things, because that's what can happen when you get very complex patients come in, their symptoms are complex, their histories are complex. That doesn't necessarily mean that your hypothesis has to be complex, right? Again, it's
Treatment is complex. This lady where the doctor basically cut her skull away from the back of her ear and then folded her whole ear over her face so that he could get at the piece he needed to get at. So where she was tender, you could feel the skull, and then there was a little ditch, and then there was the back of her ear. And I thought, what are my fingers on? In between the bone? What is that that's in the little ditch? And this little yellow flashing light went off in my head, and it said, that's the dura. Oops. So what's wrong with the dura? If somebody did that to me and I was the dura, I would be torn and broken.
Yeah.
So I started running torn and broken in the dura. And y'all have to realize that in 30 years, I've never used the frequency combination torn and broken and the dura. And it went from feeling like saran wrap, filling in and feeling firm. And once it was firm, then what was sore was the bone. What's the edge of the bone called? That's periosteum. That's easy. What's wrong with it? Somebody took a knife and cut it. And then this tissue has been pulling on it. So if I was the periosteum, I'd be pretty inflamed and maybe torn and broken. So if you want to know if it's inflamed periosteum, you run 40 on A and 783 on B, and it either works or it doesn't. I did a lot of guesswork last week, making stuff up.
Yeah, but it's not though. Those are all very educated breadcrumbs to follow. There's a manual therapy technique when you've got somebody's skull cradled in your hands and you go lateral. And for those of you who are just listening on the podcast, my hands are lateral, and you move your hands in opposite circles, and you could feel the scalp and the tissue, and you can put your fingers underneath the suboccipits. And it's such a beautiful way of feeling everything. So when I am thinking about the dura and that light does go off and you think, really? But then you run it, and torn and broken in the dura to me has been one of my favorites, and it's almost instantaneous. Yeah, how, and then as a manual therapist, it just feels more slippery. Everything along the scalp, the suboccipits, all that. And if you think about too, even just the way the traps, the trapezius muscle, its attachments go all the way up the base of the skull. And how many of us are just, even without surgical intervention, are forward, we're extended, we're on our phones. That's why, to me, coupling manual therapy with your hypothesis with the device is instrumental on getting it right. You can feel that observational change happening instantaneously.
Yeah. And the truisms are still true no matter where they come from. So this lady said, as I'm treating her, she said, oh yeah, I have this pain in my left eyeball. And it's like, left eyeball pain is the C2-3 facet. That would have come from the position your head was in as they were doing that thing to your ear. So let's try just inflammation in the cartilage.
Right.
I did inflammation in the cartilage, and I said, how does your eye feel? And she said, it doesn't hurt anymore. Okay. So that was pretty straightforward.
Right.
So the CustomCare she went home with had facet pain and neck pain on it. And then I could give her separate frequencies because this gamma knife middle branch of the trigeminal would come and go if I ran increased secretions in the nerve. The first time I ran it, it ramped the pain up. Then I did scar tissue in the nerve and mobilized it and got rid of the cut that the Gamma knife put in and the scar tissue. And then we ran 81, then we ran 40, quiet the nerve, and then 81 increased secretions in the nerve. And she said, it's not numb anymore and it doesn't hurt. So there was a progression that made sense
Yeah.
if you anthropomorphize the tissue and sympathized with what happened to it, the poor thing.
Yeah, I liked how you said, if I was the juror and this happened to me, and again, it's telling the story, it's figuring out the driver or the mechanism of action. Things just don't scar for no reason at all. They scar because once upon a time they were torn and they bled and there was trauma. And so if you just go back and think about, you're seeing the tissue in the present time of the snippet, but what happened to it before? I'm sure it's similar to the psychologist and the counseling background. You have a person that has all this anger, all this, like, how did you get here? We're not born like this. So what was the trauma that you experienced that led you? So again, it's going back and figuring out the story.
When did it start? And hearing today, we had the pre-conference day. We had the pre-conference day with Jeff Bland and Mark Hyman. And Mark especially was talking about the timeline. And I didn't realize that IFM was where I learned that you're talking about precursors, triggering events, mediators, what caused it, what perpetuates it, what happened. You were fine until something happened. It doesn't come from space. And IFM is where I had that mindset as I was developing FSM, but I didn't incorporate it into FSM until almost 15 years later. And but it was part of the way I was thinking, but I wasn't teaching FSM that way until about 8 years ago?
Right.
It's
Yeah.
made a huge difference.
And just think about how that mindset is changing medicine and the way we're treating everything from autoimmune to any kind of genetic problem. You don't treat it where it's at. You have to treat it where it started.
Exactly. Treat it where it started. Treat the cause.
Yeah.
And then sometimes you do have to manage the symptoms at the back end so the patient can survive until you can go back and clean up the mess that started it.
Right. Like inflammation and scarring in the nerve, right? I get it. The nerve is inflamed for something. The nerve is scarred from something, but you have to treat the pain.
Yeah. Same thing with the gut. When I'm talking to this functional medicine family practice doc, I said, so when you talk to somebody who has irritable bowel, you are going to tell them you have to get off these 6 foods and you need to take these supplements. And in 3 months, you're going to feel better. And your compliance is someplace between 30 and 50%.
Oh.
But you have the conversation, you get their timeline, and then you say, I have something that might make your tummy feel better and it will help your intestines heal. Would you mind if I tried it? Does it hurt? No. Okay. So you put contacts in back, contacts in front, and you treat dysbiosis, you treat torn and broken or leaking, and you treat inflammation and vitality, some pus encapsulated and fermentative and putrefactive toxin. And they get off the table, the bloating is gone, the pain is gone. Then you tell them, I want 6 weeks without these 6 foods. Why 6 weeks? 6 weeks from this Friday, you can have all 6 of those foods in one day, as much as you want. Why Friday? Because if I'm right, by Saturday, you're going to be so sick, we won't ever have to have this conversation again. But what we buy them in functional medicine, and for the MDs and the non-physical medicine practitioners that are listening, what we buy them is compliance.
Right.
When they get up off the table and their symptoms are gone now, you start from a different place. They'll come in twice a week, and that way you can check in with their diet. And in 6 weeks, they are where they would have been in 3 months. So the whole thing gets shorter. So the visceral section, which I have to blow by on Sundays, probably the most value. We do so much with the central nervous system and with physical medicine that I shortchange the visceral system, but it's so valuable.
Yes. And I know it's funny because we had Mother's Day, and I always think about the Mother's Day that you were teaching in Calgary. That was the one time that you came up. And that was like the mother idea of me teaching the sports course, because it was like 99% physical medicine, chiropractors and PTs and trainers that were in that class. And when you were teaching the visceral stuff with so many, especially the male practitioners, they were on their phone, checking Facebook, doing their billing. And I'm like, you have to listen to this because the gut is going to help the recovery. That's going to help the healing. That's going to help the scar tissue. But they didn't get that stuff initially. So I'm like, how about if I give them like a little appetizer sports course, and
Yes.
then they'll see the relevance in, okay, I need to treat the nervous system. I need to treat the gut. I need to treat all these things, the adrenals, all the other factors. And then, so
Until the gut works, nothing works.
yeah. And I don't think people truly understand that when I'm dealing with teenagers that have terrible itchy scalps, terrible hair, terrible skin. I talk to their mom about food sensitivities and they're just like, what? I'm like, and I'm not sure if it's Chinese. There's a correlation to what's happening on the skin is happening in the gut. But it's a very hard pill to swallow, no pun intended, to cut out dairy and gluten in a lot of people. Like it's everywhere, but how bad do you want to feel better? And so the compliance part that you were talking about is very important. And and you just said it, like go off of it and then get super sick when you have it, and you never want to feel like that again. So that is enough.
You finally make the connection.
Yeah. So many of us are kinesthetic learners, right? Like you just have to go through it and feel it to really understand it.
And you taught me that with your autoimmune thing.
Yeah.
It's dairy.
Yeah.
And your rheumatologist told you to go off dairy.
Yeah.
How did she decide on dairy and not gluten or corn or soy?
I was already off of gluten. So she said that is the #1 inflammatory contributor to autoimmune. She's like, but since you've been off of it, and I've been off of it for, I want to say 2-3 years, she's like, the next thing, because she knew I was as holistic as I could be. And she even said, let's try to do this holistically first, because the medications are slippery slope once we start. So her idea was to always treat holistically until that stopped working. And then you have to have medical intervention, which I appreciated. So she said the next inflammatory culprit for autoimmune was dairy. And I said, sure, no problem. And she's, oh, okay. And then make sure that the soy and the corn were limited and organic if I were to have them, because if you go off of gluten, the corn is like a big
Contaminant.
cross contaminant. But if you're going from Mexican, you're saying, okay, I don't have a flour tortilla. Well, we'll have corn. So it's a big substitute. So she just said, try to have those substitutes as clean as possible. Right. And that was easy for me. I made that change. And I didn't realize I was reacting to dairy until, again, I went off of it, because sometimes it's not super noticeable. Sometimes gluten for me was big. I didn't realize how bloated I was until all of a sudden I'm like, wow, I'm not bloated. I had brain fog when I didn't realize I had brain fog. So sometimes it's small. For me, I just had the buy-in that if I have a chance of shutting off something or not having something express itself, why wouldn't I avoid that?
The whole concept of epigenetics.
Yes.
Have on-off switches, and they are bathed in whatever you eat, whatever you think, whatever you feel.
Yeah.
That's what affects your genes.
Yes.
This whole concept that a diagnosis comes from some place, there
Yes.
is a cause,
Yes.
and if you can address the cause, it's like,
Yep.
sometimes we can't address the cause. You
Absolutely.
had an auto accident, you were rear-ended at 40 miles an hour, it crushed the cartilage, it gave you microfractures, and the bone is inflamed and degenerated, and it's a maintenance problem. It's going to take me twice a week for 4 to 6 weeks. And then we'll see how long it lasts. I can't fix the cause because I can't undo the car accident, the bicycle accident, the whatever.
Right.
In physical medicine, sometimes we can't fix the cause. We just clean up the collateral damage and restore function the best that we can. And in visceral medicine, the concept that visceral problems have a cause, the fact that your rheumatologist recognized that dairy could cause a positive ANA. I had a rheumatologist in my core class who said with a completely straight face, everybody, there are autoantibodies all the time. Sometimes they just get activated. And she was so convinced that was her worldview.
Right.
I wasn't about to undo it.
And she's right. Yeah. There's tons of people that have, if you went digging and did ANA panels, would be positive and they have zero symptoms. But I don't buy it that things just turn on or turn off.
Accidentally.
I don't.
Yeah.
So, I don't know. To me, the analogy is if you're driving a car and you're going downhill and there's a sign saying there's a massive drop off if you keep going straight and you have the choice to turn right, why wouldn't you choose to avoid falling off a cliff, right? It's a choice and you just choose it.
Yeah.
You're right though. And that's the alarm that it's 4 o'clock and
It's not. It is.
I feel like I'm very angry right now that it's 4 o'clock because I feel like we've just scratched this. This is what happens when there is a bit of a lapse in our talks.
The funnest part is having a tool that people can learn to use more and more effectively. It's the same tool.
Yeah.
And you just learn to think about it differently.
Yeah.
And use it more creatively.
Yes.
And having that tool is like the coolest thing.
It
Having
is.
Susan burst into tears.
How could you not? When you see those little miracles. And Julian, we're going to save your question for next week, unless you want to do it super fast.
Where'd Julian go?
It's wrestler's ear caused by blood clot or hematoma. Can FSM treat this? So cauliflower ear, restless ear is when the tissue is damaged on the outer surface of the ear and it's like a piece of cauliflower.
Yeah. It's a combination of 13 and 284
Yeah.
and 77 probably.
I don't have any mileage treating cauliflower ear.
I've never treated cauliflower ear, but you look at the ear, there's only so many tissues. This is cartilage.
Yeah.
That's the ear is cartilage.
Yeah.
Then there's a little layer of capillaries. And then there's a little teeny layer of adipose.
Yeah. Fascia's everywhere.
Connective tissue.
Yep.
And then somebody beats the heck out of your ear while you're going to have a hematoma. What is that going to lead to? That's going to lead to scar tissue. Yep. And so.
Try it, take pictures before and after and let us know.
Yeah, that'll be cool.
All right, we have to go.
Okay, fine. See you next week. I'm going to be here next week, aren't I?
Yeah, we'll be on next week.
Yay.
All right.
Okay.
We'll see you next week. We'll see everybody here next week. Keep the questions coming.
Yes.
And we'll see you then.
Do good things.
Thank you.
Talk to you later.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.